Good evening, ladies and gentlemen. Am I audible?
Yes, you are. Please go ahead. Please go ahead.
Good evening, ladies and gentlemen. A warm welcome to the Learn from the Legend series, hosted by Indian Academy of Pediatrics Neonatology Chapter and NNF Kerala. Today, we have a legend from Canada. It's none other than Professor Prakesh Shah from the University of Toronto, Canada. He will speak to us on the quality improvement initiatives in NICU, the 5 Ws. As the moderators will make a formal introduction, I will not dwell into it. Rather, I will give a brief introduction about the moderators. Professor Vikram Datta, Department of Neonatology, Lady Harding Medical College, New Delhi, and President, National Quality of Care Network. And Dr. Adi Shivam, Professor of Neonatology, Jitmar, Pondicherry, is interested in human milk banking and essential newborn care. Over to the moderators, kindly take over. I wish you all an academic feast tonight. Thank you.
Thank you so much, Dr. Ravi, Dr. Manoj. Very warm good evening to all friends in this international webinar, and a warm welcome to our eminent speaker, Professor Prakesh Shah. Now, this is a topic which is very, very vital today, more so in the context of the COVID pandemic. And as friends, all of you are aware, we all talk about quality. Quality is a common sense approach, but it is sometimes very difficult to really implement quality. And there are challenges more so in fragile settings, especially in the wake of pandemic. So today we have Professor Shah. The detailed description of Sir's eminent profile is going to be provided by my co-moderator, Dr. Adi Shivam. Professor Shah is going to talk about the basics of quality in neonatal care, the 5 Ws. And what Sir is going to address today is, I would just start with a brief context. A recent Lancet Global Commission report on high quality health systems in 2018 evaluated the health systems of low and middle income countries and found that quality of care or lack of proper quality of care is leading to the majority of deaths which are happening in these countries. And over 5 million deaths are happening because of poor quality of care, and nearly 3.6 million deaths are happening because of lack of access to care. So if we combine both of these things together, then this is what is leading to a large chunk of newborns losing their lives. The largest killer because of poor quality of care is the cardiovascular disorder. And the second largest killer after that is the neonatal disorders. So Dr. Shah today is going to talk about what is quality improvement. Sir is going to demystify the approach of quality improvement, why we should adopt quality improvement into our day-to-day clinical practice, when we should consider the approach of quality improvement over quality assurance. There is a lot of confusion. We go for a lot of certifications and we get the JCI, NABH, a lot of certifications. But what is quality improvement and how it is different from quality assurance? And is it one and the same, or these are the two sides of the same coin? Sir is going to clarify. Which method of quality improvement should we use? There are a lot of methods. If you just Google it, you will get n number of methods. And sometimes at the point of care, the teams are confused. And lastly, from Sir's rich experience, Professor Shah is going to talk about which method you should choose as an end user to demystify the approach of quality improvement to improve the neonatal perinatal outcomes. So with this brief introduction, I hand over to my co-moderator, Professor Adi Shivam. Dr. Adi Shivam is going to be giving an introduction of SIRS profile. Thank you so much.
Thank you, sir. It's indeed my privilege to introduce the legend for today's evening. Dr. Prakesh Shah is the pediatrician in chief at Mount Sinai Hospital, Toronto, and professor in the Department of Pediatrics and Institute of Health Policy, Management and Evaluation at the University of Toronto, Canada. He is the director of Canadian Neonatal Networks, CNN, Canadian Preterm Birth Network, CPTBN, and an international network for evaluation of outcomes of neonates, INEO, whereby he oversees a project of benchmarking outcomes of very preterm neonates in 11 countries with the population level neonatal networks with a final aim of improving quality of care across 240 NICUs. His areas of interest include patient and disease-oriented research in neonatal and perinatal medicine, health services and epidemiological research in maternal newborn care, knowledge synthesis, and quality improvement. He has evaluated and produced policy documents on interventions and programs for primary, secondary, and tertiary prevention of preterm birth for provincial and national agencies. He is engaged in policy and advocacy work with his role in executive committees and advisory board membership as local, provincial, national, and international levels. He currently leads the National Evidence-Based Practices to Improve Quality initiative in Canada. Over to you, sir.
Please unmute, sir.
Thank you very much. Thank you very much, Dr. Datta and Dr. Adisivam for the introduction. And I'm proud and privileged to be talking to you all at this webinar. And it gives me immense pleasure to talking to you, as well as knowing that I'll be talking to the colleagues, and there is nothing that I know that you don't know. That's the first confession I want to make. So I'm just going to simplify and give you some tips from the learned experience in Canada as to how and what we went about in quality improvement for last 17 years, and what has that done to the premature babies in Canada. With that, I just want to mention that slides are not advancing. Okay. I have nothing to disclose. There is no conflict of interest. I would not be talking about any medication or any drug or any licensed or unlicensed product. And that's what I try to concentrate today, because I have been attending this webinar as well and have been seeing the disease-oriented or the pathology-oriented talks. And I thought it is time now to merge everything together and see whether we can make something that really helps. So my objective is, what is quality improvement, when quality improvement, and when quality assurance and quality control. Why should we do quality improvement? If we do it, if we decide to go ahead, then which method we should be using, and what really helps at the front line. Those are my 5 objectives, and I'll be happy to answer any other questions that arise at the end of the seminar. A bit of history about quality improvement. We could not go further without acknowledging the giants who have been working in this field, starting from the most left, which is Dr. Walter Shewhart. Many of you might have known Shewhart's charts, and he was working at Western Electric, and that's where he started developing these statistical processes and control chart. On the extreme right is Edward Deming, who introduced the quality improvement concept, both from the industry into the healthcare. Don Barwick is a pediatrician from Boston and ex-president of Institute of Health Improvement in the US, who is currently leading as well as being the most vocalist as to how and what to do, and Paul Batalden, who is also from the UK. What you will see at the bottom are the bit of snippets from these giants that will pop in the different slides time and again. And these are very important one that started the quality improvement work. Every system is perfectly designed to achieve the result it gets. If you don't work, if you don't try, and if you don't work on improve it, you just will continue to get the same results and the things will not change. So you will see their snippets coming at the individual slides, not every slide, but some of the slides, and those are important quotes. I would not be speaking on those quotes. So what is quality improvement? You will see multiple definitions of quality improvement. It's a systemic data-guided activities designed to bring about immediate improvements in healthcare delivery in particular settings. This is kind of a simplest of the definition, but you can complicate it, you can make it convoluted, but idea is that you want to improve. And that's all we all care about. We all come to work to improve. And other aspect is it's a deliberate and defined process, which is focused on activity that are responsive to local needs and improve health. It has to be continuous. It has to be an ongoing effort to improvement. But at the same time, it should result in a measurable improvement in efficiency or effectiveness or performance or accountability, equity, and ultimately the outcomes. And that is the goal. We all come to work and we all want to do this on an everyday basis, on an every moment basis, with every patient, with every healthcare facility, and with every system. However, it has been a plethora of ideas that you will come across as to what to do, how to begin. So there are a lot of very nice articles written by by many people as to how and what. What everybody struggles is that, okay, well, in this maze, what do I do and how do I go about it? And that's where the matrices come into play, is what is quality assurance, what is quality control, and what is quality improvement. So let me just with a simple example, demystify that concept. Quality assurance is, let's say you in a state of Kerala, there are 100 neonatal units. Some are performing better, some are performing worse. And you can see that it would be kind of a bell curve. What you want in the quality assurance is basically you want to close those institutes which are in this side. That is quality insurance, because you just don't want, you can't accept this. Quality improvement is not that. Quality improvement is not to just, okay, well, let's shut it off and then we go here. And then by that virtue, keep on cutting and come towards the left side. By doing that, you will suffer because you won't be able to provide proper access to the care to many who probably are living in this region. Your total improvement will occur because your central bar will move to the left, but there will be people who will be suffering. So that's not quality improvement. That's quality assurance. So a simple example is that you want to have a sink at each of your isolate in your neonatal intensive care unit. Now, to have a sink between every 4 isolate, that's quality assurance. So that is a process, that is a standard, that we should have a sink to wash hands between 4 bed spaces. So that's a standardization. So if you don't, that means you are failing the quality assurance. Quality control is that sink has a soap and a hot and warm water to wash hand. That is quality control, that the temperature in that tap is appropriate so that people use it or people can use it comfortably. So what is coming out of that water, or where is the soap dispenser appropriately placed or not? Those are quality control measures. These are reactive. If it is too cold, you increase the temperature. If it is too hot water coming out, you decrease the temperature to identify issue, to meet the quality assurance goal, that there is a functioning sink between the 4 isolates. What quality improvement is making people use it. That's a quality improvement, because if having 4 sinks, you have met the quality control criteria. Having proper water and soap, you have met the quality assurance criteria. But if people don't use it, those sinks are useless. And that is quality improvement. So what you see here, same graph that I showed you before. So there are this many units, and there are some units which are not performing. The idea is to bring those units to perform better. But at the same time, you don't want to penalize those who are working harder and continue to improve quality, improve their outcome. So what you want to do is to improve everybody's performance so that everybody moves towards the left. Your central bar will move towards the left, but at the same time, the variation is reduced. The variation between the unit outcomes also reduces, because you don't want to go to the south of Kerala to get a better outcome versus north of Kerala. You want the whole Kerala to have similar outcome. And that is quality improvement. How do we work with individual units so that everyone gets better, everyone gets closer to each other? And that is very, very nice in theory, nice to understand, but very difficult to achieve on a local scale, on a state scale, or on a national scale. And these are the differences between quality assurance, quality control, and quality improvement. So I'll be concentrating on quality improvement. And why? Why quality? Why can't I do a fantastic research that is innovative, a new drug, a new molecule, rather than worrying about what is happening as quality improvement and stuff? And so there are 3 spectrum of it. One is quality improvement, meaning thereby applying what you know and doing it better. Another one is imitation. Let's see what the other unit is doing across the street or across the city and try to imitate them. Whereas the third aspect of it is to innovate and create a new model that works for you and not just imitating completely. There are good things about the imitation that you take and then innovate in your local setting. And that's the innovation spectrum for the quality improvement. So yes, you can do a new randomized control trial of a fantastic molecule and improve quality, but there is more to it, because we need to focus on quality, because there is no limit to what is better in quality. The second thing is, none of us are getting new money or new support to improve care. We just have to work with whatever existing system we all have in front of us, available to us. And that's why we need to do better with what we have rather than expect that it will change. And it is highlighted nicely in this slide. What is progress? Science is progressing fast, but we all know the patient care does not follow. And that is the quality gap that we want to fill. And that's what you can move this bar towards there, so that we follow science. I'm not saying that every new randomized control trial you have to adopt, but you follow the science in such a way that it will reduce this gap. Meaning thereby what Edward Deming said, it's not enough to do your best. You must know what you're doing and then do your best. Because you just think that you are doing best, but you need to know what is the best and then try to do the better for yourself. Because what has happened in the last few years, we are constantly changing. Neonatal intensive care is at the cusp of constant change. And what has happened from 1970s to 2020s? When we started with ventilation and CPAP, in 80s we had steroid, in 19s we found surfactant, in 2000 we had nitric oxide and ECMO. Since then, what have we done? Just try to be gentler, avoid mechanical ventilation, integrate family into the care. And in the last decade, it's just how can we do it better, what we know, and how can we do it consistently? So I'm a firm believer there is a big place of randomized studies in neonatal care. But what has happened in the last 10 to 15 years is that no new things have arrived. What we have learned is what we were doing, let's hold back and let's do it gently. And that's where quality improvement has proliferated in the last 2 decades. And unless we do quality improvement, the items we know are not being implemented. And and correctly implemented with the local settings in perspective. So with that, what background, what I'll do is I'll just give you some of the information from an humble experience that we have in Canada, integrating all this concept, as well as at the same time trying to tell you what and how to do the quality improvement. So Canadian Neonatal Network is a network of all tertiary care NICUs in Canada. And we are 32 sites in Canada, which are part of the network, and everyone is a part of this quality improvement as well as the database network. And one of the common thing that happens is we are not same. You can see there are units which admit less than 100 babies, and there are units which admit more than 1,200 babies. So we are similar, but we are different. We are similar in the sense that we come from the same funded national health system, but at the same time, we don't care equal number of babies, and there are differences. And in this context, what we found in the first paper in 2002, when we published data from 1996-97, there is a huge variation in mortality. There's accrued rate varied from 1% to 10%. And one would wonder that why in a healthcare system, which is completely accessible, no barriers, such a large variation. And that's where the seeds in 2002, 2003 were planted regarding the quality improvement. Other thing that happened in around 2010-12 is we started that journey. We had a 10 years of results, which I'll show you. But in 2012, we had a fellow, Dr. Isayama, came from Japan to do fellowship in Canada. And after 6 months, I was asking him, what is he finding? He said, well, there is a big difference between Japan and Canada. The blue is Japan, red is Canada. And you can see the number of babies with mortality or any major morbidity is significantly high in Canada compared to Japan at less than 26 weeks. Whereas when you go down to 27 to 32 weeks, it's better in Canada. And we were scratching our head as to why, what is happening, like what? And that it's the concentration that they had in terms of what kind of baby. But then we started looking into the details to learn that, okay, well, is there something that we can learn from Japan? And we found that PPD and severe ROP were significantly lower in Canada, whereas NEC and sepsis were significantly higher in Canada compared to Japan. And that just started a kind of a discussion as to what is happening, like why something is better here, something is better there, what differences are we doing and how we are doing. And that's where I have we established international network. And I'm just showing you some of the results here. This box, I will open it later, but you can see the red line is Canada. This is Canada, Australia, Israel, Japan, Sweden, Switzerland, Spain, UK, Finland, and Tuscany. And you can see we were composite outcome, adverse outcome, we were the worst in 2007 among these 11 high income countries. And that sparked a lot of discussion within our network as to how do we do it? How can we improve the outcome and how can we be better compared to our colleagues? So the seeds were local, based on our local data, as well as once we got comfortable with the local data was based on an international comparison as to see outside and see what others are doing and how can we learn? How can we build that social capital, encourage values, and design a system which works for evaluation? In the initial phases, we were just data collecting system. Oh, give me your data, collect the data, and produce annual report, but not further. What we have grown from there to now is to convert that into information, community, collaboration, knowledge, and getting wiser. I don't think we are completely wise yet, but getting wiser every step of the way. So how did we do it? We basically embraced the quality improvement concept. And which method did we embrace? So again, we were at the same stage as, okay, what do we do? There are so many of them out there. You can do clinical audit. You might have heard the word lean method, Six Sigma, total quality management, benchmarking. And I'll show you each one with advantage, disadvantages. Clinical audits are always good. I mean, you just see what clinical care meets your defined standards that you want to provide and how many times you are providing that particular clinical care. You can monitor their improvement, address shortfalls, and quickly address them. Example is hand washing audits, reports that we generate for our unit, that somebody watches who is washing, who is not washing, and create a benchmark and target for improvement. So it's a simple method, and there is nothing wrong with it. There's nothing wrong. You should do it and you should continue. But many times it falls into the realm of quality control or quality assurance. Unless you take it to the next step, okay, now our hand washing is 49%. What can we do to better? That's where the quality improvement methodology will come in play. Many of you might have heard lean principles by Toyota. Again, it started in a car manufacturing company. The problem they identified was there was a lot of waste, there was a lot of duplication, and a lot of redundancy. There was flow issues, process issues. Those are the things that lean principles address. And the idea is that if you have a systematic problem, your system will be as good as the results that it gets. So focus and strength, it eliminates weight, reduces redundancy, improves your flow, and simplifies the processes. Right? I mean, if your system is not right, it will beat a good person every step of the way. So that led to another measure that came in that realm as well, called Six Sigma. It's a process where it's a DMAIC principle, where problem is poor quality, high variation, the variation that I showed you, and there are complex interaction. So this, many times, many people have adopted this system because that works, because our system is not straightforward. There are a lot of complex interaction. So what it helps you to reduce variation, it uses the data and goes in cycle, and it can create a robust control system. So there's nothing wrong with this method as well, and it has been shown to be effective in many, many settings. Institute of Health Improvement has adopted principles based on the total quality management, which addresses basically flow issues, local problem, and does not require much resources. Its focus and strength, it has aim, you develop your learning goals, you run this into total quality management cycles, and you can address multiple situations simultaneously because that will be interacting. So you want to reduce necrotizing enterocolitis and reduce infection, you can work two systems together to work out what are the common, what are the specific things to address those morbidities. And then performance benchmarking would be that addresses basically performance issue. It compares the inefficiency in the system rather than efficiencies. However, if you have a problem with the data, you cannot use this. So you need continuous data. You need to develop continuous quality performance improvement measures and continue to produce those visual display. And you need to be aware. So one of the things that will come out of my talk is that without data, you are another person with an opinion. And I think data is very, very important. You need to look at your data to see what and where there is a room for improvement. What are the tools? There are multiple tools are also available for quality improvement. And those are like a driver diagram, affinity diagram, process mapping, Pareto chart, root cause analysis, fishbone diagram, PDSA cycles. All these are very, very useful tools. Does not matter which one you use and how you use it. Just choose one and follow. And I'll show you what we have chosen and how that has helped us. So we call that as evidence-based practice for improving quality, or EPIC in a short form, EPIQ, and that's the term I will use. But the idea was to promote dialogue through development of teams within your unit. And then between the teams, share and evaluate data, share best practices. And between the units and between amongst the whole country, we basically shared the best practices, intervention, and their results. And that is what gave us what I'm going to show you some example. We also taught quality improvement to our individual units. And this is courtesy of Dr. Khalid Aziz, who has been our lead tutor for every unit to see how we do this quality improvement. And he simplified for us in simple 10 steps. First 3 steps are understanding. Then what do I mean by understanding? Identify the problem. Okay, just look at your unit and see what is the problem. If babies are cold is a problem, why are babies getting a cold and why it is a problem? Why can't they make enough heat? Why aren't they doing skin to skin? And why are staff not aware? So first issue is to identify what is the problem. Ask those 5 whys. Then you need to select a team that will work on this problem. Who do you need on your team? Ideally 4 to 4, 6, 8 people, not more, but identify who is going to help you in each step. There should be one recorder, facilitator, or coordinator, but otherwise include different professions, managers, providers, your leaders, and then complete an analysis as to what is each one's role. And then sit down and brainstorm the causes. Causes are people, place, procedure, and policies. And then identify what is the issue. That 30% of babies are not receiving skin to skin care, or 30% of the babies are getting cold when the temperature is measured at 1 hour of age. And when you go back, you will find that there is problem with the people or place or procedure or policies. Make this diagram simple so that people can look at it and then identify where are the problems. And then choose a priority. You're not going to handle each and every of this problem as soon as you start a quality improvement process. You need to prioritize. And priority comes with a discussion in the group. Which part of the problem is in your control? Which part is impactful? What is manageable? What is affordable? And what is measurable? And you can see this example of 3 different aspects of preventing babies getting cold. Place a hat on every baby, use a warm blanket, raise room temperature, and ask people to give score between 1, 2, and 3, 3 being the highest. And then you can see that place a hat on every baby is found to be aggregate score of 13, which is in your control, impactful, manageable, affordable, and it's measurable how many babies have had. So just break it down in a simplified process. And then once you have chosen the priority, map out the process, that how could it work, right? The baby is born, and then you work out, okay, each and individual step. The diamonds are decision points. If the baby need help to breathe, no or yes. If it is no, what happens? If it is yes, what happens? So you create this whole flow map of the quality improvement activity that you want to do. And then at the same time, you have to have a balancing indicator. You want to make sure that you are not cooking the baby. You're not making these babies hyperthermic. So you need to measure that too, that how many babies are hyperthermic, more than 37.5, sorry, not less. And proportion getting into the breast milk, because if you're focusing on one aspect, you may forget the breastfeeding part. So you just need to have some balancing indicators. So identify your indicator both on the left and the right side. Put all this thing in your aim statement. Explain what you want to achieve. What is this domain of quality? What is your aim statement? What are the processes? And why this change is important? So the whole team, not only the leadership team, but the whole team working in your unit knows this is our aim and this is what we want to do. Now, the next thing is engage the partners. Who are the partners? Just decide or discuss. It could be parents, it could be staff, and it would be administration. And what level they are in terms of engagement. Parents are unaware that they have to put a hat. I don't think any parents would know at the birth, unless you had a previous baby. Are they thinking, yes, my baby is cold? They are thinking, but they're not doing anything because they can't do plan, act, or do anything. Staff are thinking, but they are not at the planning or acting stage. And administration is completely unaware that this is an issue. unless you bring it to their attention. So engage all your partners, bring them into the same plane level field, and then plan a process. We do it as a PDSA cycle. So the first one is had, the second one is another one, third one, fourth one. So you do it in succession to gain the to not to lose the gain from the first one, but to add, and add, continue. So, but in the initial stages, aim for early successes. Aim for the one that will give you immediate result, make the team happy, make the team enthusiastic, and then the team will be wanting to work. Okay, what do we do next? How do we brought it down from 30% to 15%. How do we bring it down from 15 to 10%, to 5%, to 0%? How can we progress? Remember that later changes would be hard one. And then do that group work and then present and let others know. Let your team know what is happening, what are your results, whether it went the way you wanted or did not go the way you wanted. We do this workshop as to how to do it, and Dr. Aziz has done it internationally. Australia has adopted the similar concept, and they're working on, and we have done it in the South America as well. This workshop at the moment are at the courtesy of run through the University of Alberta, and not that expensive to start with, but eventually it will. I mean, there are so many other programs that you can attend to learn about quality improvement as well. I'm not trying to sell anything here. But share your knowledge with the data and with the process control chart. This is a process run. This is called run chart, where you see January, February, March, April to December, how many babies were hypothermic in each month. And you can see they were fluctuating between 5, 6 to 10, 5 to 8. As soon as you started skin to scare staff training, the numbers started to reduce. And show this visual display not only to your unit, but the unit across, to present it so that people can know what is happening and what can work. Right? Now, the problem occurs in this is the sustainability, because this can happen. You can have a nice improvement, and then if you put your guards down, it will revert back to normal, believe me. And I'll show you our journey from 2002 onwards, when I showed you the mortality difference chart, to now as to what. Our conceptual model was data. Input was the data and reviews. Data meaning thereby data of their individual unit that we collected. And the reviews are the reviews in the systematic reviews of the literature to find out what works for which particular condition. We processed, we analyzed, we look at our own data, individual units, and then plan that, okay, what do we want to target? We have problem in 5 morbidities. We can't tackle all 5 at the same time. Let's start with this one that is low hanging fruit, show improvement in the unit so that everybody is enthusiastic, and then go. And we continue to feed them with the output to implement, and then continue back with the input, process, and output. So that was our concept. Just to give you an example, here is the baby who is born, and by the time the baby gets surfactant, baby has to pass 14 steps, because the unit had different, you have to have a line placement, you have to have an X-ray, you have to have a blood gas, then wait, then X-ray, then wait. It was 14 steps before surfactant was given for the baby who is requiring surfactant now. So the unit sat down and then worked out the process. What did they find? There were 2 programs. Surfactant was coming from one program and the budget was coming from another program. They had old criteria. They needed a chest X-ray. Their old protocols. There was supply and storage issue. There was a physician order issue. So they worked out the PDSA cycle, and they found out what are the problems and how to tackle those obstacles. They obtained agreement between the 2 budget departments that surfactant would be available where baby is born, not in the fridge 2 kilometers away. And this is what happened. The baby, their target was to give surfactant within 30 minutes, and there was only 3 steps after the process. And how did they monitor? This is their surfactant tracking sheet. This is the time in minutes, and this is the time in years or months. And you can see it went from 350 minutes down to around 80 minutes. Still, they haven't reached the 30 minutes, so they still need to continue to work, but you can see that it is starting to fall in the babies who were admitted to their unit. So with that background and that example, what I'll show you is the first part in 2002. Now you have to turn your clock back to 2000 when quality improvement was very new. Randomized control was the only trials were the only way that you can generate evidence or talk about evidence. So we did first cluster randomized control trial. We asked 6 units to work on nosocomial infection. We asked 6 units to work on BPD, concentrate on BPD and target BPD. And the 5 units, we say, well, we don't have enough manpower to work. So we just say, well, you just continue what you're doing. So they acted as a control. And what we found, units working for infection reduced 34% infection rate. Their BPD went down because, as you all know, infection goes down, BPD will go down, went down by 44%. BPD group reduced BPD, not much change in infection. Importantly, there was no change in the control. Helping us to understand that this is effective in reducing infection and BPD. If you target one outcome, you may affect another outcome, and this may be more effective. I mean, we could have done randomized control trial of one intervention in the cost that we did, where here it was many intervention ultimately resulting into reduction in infection and reduction in cost. We were very happy in 5. We said, oh, that's great. Nation is on the best track and we don't have to worry. So we just basically told people, do whatever you want to do. The unit which did not participate came and say, oh, we want to know, how did you do it? So we just gave them that this is what we did, a paper, not immersive engagement of training, team development, and acting as a quality improvement. And what we found, the hospitals who had immersive engagement continued to improve. Hospitals which were just given paper, oh, this is what works, and then left as to what you want to do with it, nothing happened, nothing. And that gave us a quick idea that just disseminating and does not help. You need to disseminate and reinforce the concept of quality improvement. Just telling units what we did without complete process of immersive engagement, it's not going to be effective. And this is what is required. So we did not put our guards down and launch the second cycle. But as you can understand, now we couldn't do a randomized control trial. We had to do quality improvement. So we targeted all NICUs. We targeted babies who are less than 29 weeks. We targeted 5 major morbidities: neck, BPD, infection, bleeding, intracranial bleeding, ROP, and mortality, and plan to measure the neurodevelopmental outcome. Again, did a systematic review process for each morbidity, developed a virtual community where people can interact, develop some local indicators. Because locally, if you want to do something, you need to have an indicator to see that it is helping you and check it. We developed regional conferences, training workshop, and we found 37% reduction in odds between baseline to year 3 in composite outcome. But we also learned that most of the improvement occurred in 26 to 29 weeks and not in 22 to 25 weeks. So there is some room for it, still work to be done. And we also learned that the improvement occurred in outcomes of ROP, necrotizing enterocolitis, and infection. BPD and IVH did not change much. So those are the learning lessons which we basically indicated. But it proved us that it is effective. You can improve one outcome to the other outcome, and it is generalizable because now 25 of the 30 units were practicing the quality improvement and were part of this this engagement. So we launched immediately EPIC 3 because at this time there were people coming and saying that, look, we did not have an infection in our unit for 180 days, 200 days. And we say, well, if you can get to 0, why can't everybody get to 0? And that was the idea. So next 5 years was sustaining, as well as going and learning from the good sites which were performing good. Again, another 28% reduction in odds, composite odds for whole group, but most of the improvement again occurred in 26 to 29 week. But there were some gains in mortality, necrotizing enterocolitis, and infection happening. But in the end, I mean, we concluded that every 60 to 70 babies that are treated in Canada, this program led to 2 less deaths, 3 less neck, 4 less infection, and 10% of the baby going home without any major morbidity. This is a huge achievement when you multiply to the scale of a national level, and also proved that it is sustainable. So what it has shown, what I've shown you is that it is scientific with a randomized control trial. You need to learn what works and what does not. It is generalizable, it is sustainable, and we are currently in the fourth phase, which is advancement. And I don't have time to detail you as to what next steps we have taken, but it's basically taking common intervention and comparing common intervention between the units. However, when I show you the broken down epochs, you shouldn't be taking that as a quality improvement process, because quality improvement is a continuous process. And we wanted to see over the 14 years, is there anything change? Because you need to have data. And this is what has happened. So the survival without major morbidity at individual gestational ages. So this is 23 to 25, 26 to 28, 29 to 30, and 31 to 32. At each of that, there is a significant special cause variation, which is the term used to describe the quality improvement. And that was translated in individual morbidity as well, in terms of the BPD, IVH, NEC, ROP, and late onset sepsis. Not much in early onset sepsis. And overall, for between the 2003 and 17, we have achieved 20 to 40% reduction in adverse outcome, individual adverse outcome in the babies less than 29 weeks in Canada with the use of quality improvement process. But we also learned that there is some static point, and that's where we have gone to the other side of the umbilical cord, meaning thereby involving the perinatologists, obstetricians, maternal fetal medicine specialists, because we want to get the baby in better condition by encouraging and enhancing deferred cord clamping, judicious use of antenatal steroid, judicious use of maternal antibiotics, and other intervention, so that when baby comes out, baby is in better condition so that we do not struggle. And once they heard about this initiative, they joined. So in the last 3 years, we have worked on this and improved those aspects that I'm showing you significantly. So in the middle of this process, we started to look around and say, okay, well, how can we do even better? Or are we doing as good as what others are doing? And that's where INEO was born. And this is the half slide that I showed you. So you can see we were probably not the best or the worst, going down to the second best in the lot in 10 years or 9 year span from 2007 to 2015. Whereas majority of countries either have gone worse or remain static and not improved. So it's not that we're not trying to say that this is what works, but what we are saying is that this is what has reduced the variability. This is the recent paper where we looked at the variability in composite outcome between units in Australia, Canada, Israel, and UK. And you can see the broken line is 2016, the hard line is 2007. So in 2007 in Australia, there is a marked variability. They reduced variability, but they went to the other side. Overall outcome got worse. Israel, no change. UK, similarly reduced variability, but got worse. Whereas in Canada, we have reduced this little bit variability, but the overall outcomes have gone better. And that's the difference between the countries. Now, each of this country has same evidence available to them for randomized control trial to implement intervention. And that's what we found. So what really helps in the quality improvement? I think what really helps is the commitment from the leadership and engagement from your hospital. You need to have solid support and serious engagement of the leadership in buying in the quality improvement model. And I don't think in this day and age, it is difficult to obtain or achieve. So leaders, engagement, you motivate each other, and engagement of not only leaders, but engagement of your unit, everybody in that unit. So this is not only doctor's job, or this is not only nurse's job, it is everyone's job. And you enhance that information system, apply evidence, share results, and continue that cycle. This is what enabled us. In the EPIC, it was teamwork, appetite, everybody coming every year, sitting together and say, we are struggling for an infection. We want to know who is doing better, and we want to go and sit with them and learn from them. And that is what facilitates quality improvement. If you work, idea is to develop what is known as quality culture. When the culture within your unit or within your organization or within your local context needs to be such that you want to improve quality. And it happens with all the 6 domains that I mentioned to you: leadership commitment, staff empowerment, teamwork, continuous process, infrastructure, and patient focus. Engage parents. They will be your best resources to tell you what matters to them. However, there are things that will not help you, which is if you have a hierarchical organization that this is this person's job and this is this person's job, and there is a silo, it will not help you to do quality improvement. People are apathy. People don't like to change. Change is hard. People are overloaded. There is lack of engagement and the culture. I mean, you need to change the culture of the unit to make sure that quality improvement would be successful. Otherwise, it will not work. So before at your unit you embark, emphasize that you're interested in quality improvement, not quality assurance or quality control. You are interested in quality assurance and control, but improvement is the main target. Avoid mystical language. Don't use lean and Six Sigma and all that. Just simplify, because people do not know all those things. What and relate to what matters to clinician. Hear them. What is the problem? Accommodate to their workload. You just don't want to every 2 months throwing a new quality improvement project and people will say, well, another one, right? Provide relevant data and update those data. Highlight academic aspect and do not be afraid to tell them that this will reduce cost. And that is another agenda, that you have fiscal agenda of reducing the cost. Do not hide it. You need to be upfront with it. And that will only help. I think with that, I'd like to conclude and get some questions. So I'd like to acknowledge a lot of people that have helped us to reach there in Canada, as well as internationally, as well as the research center that I work, as well as a lot of local trainers and the group chairs and the steering committee that has helped, that are helping to drive this. And not to forget the patients and families. They are our cornerstones. Now we do quality improvement what our parents tell us, that this is what they want to see. And that's our target. That is how we do it. This is my research center where these are the people who produce this data that I'm presenting to you and showing it to you. But I'd like to end with few quotes. Like, making improvement will happen when there is unshakable belief that everyone has 2 jobs when they come to work: to do their work and improve it. And I would add, our 3rd job is to share. Let others know that this is what worked with me. It may not work with other places, but work with me. And another one from Confucius: I hear it, I'll forget. So you heard me, you'll forget. You see it, you will remember. But if I do it, you will understand. So you need to be immersively engaged and do it. And finally, our beloved Mother Teresa's quote: what you can do, I can't do it. And what I can do, you can't do it. But if we work together, we can do great things. Thank you very much.
Thank you so much, Professor Shah, for that immersive presentation. Very inspiring indeed, sir. It's been great to hear your extensive experience of putting forward a collaborative network and the EPIC 10 in Canada, and then moving on to an international network and sharing the sustained results and the comparative results from various countries. In fact, it is very, very humbling to look at the data and to learn from your experience. Great learnings from the Indian fraternity and also global colleagues who have attended to this webinar. So, sir, we have quite a few questions. So I will just start with the first question from myself. I'll take that privilege and then move to the next one. Sir, in India, we are in the process of moving towards a collaborative network. We've established the quality of care network and are working very closely with the national governments and the state players. But moving towards collaborative requires a lot of drivers and needs us to get over the bottlenecks also. So from your experience in Canada, I know the context is different from India as well as in Canada. Sir, which is a couple of key drivers which you feel, because you've been coming off and on to India. So what is your advice to our friends who are attending this webinar? How we can get such a collaborative rolling, because NNF also, way back in 2003 and 4, we rolled out the NNPD, the National Neonatology Neonatal Perinatal Database. And since then, we've been trying at NNF level also to get together a network, but not with much of a success. So your advice on the key drivers?
Yeah. So I think the first and foremost key driver I would say is that you have to have data. You have to have robust data, and you have to have a willingness to produce and like not be afraid of showing that, okay, well, my infection is high in my unit or necrotizing enterocolitis is high in my unit. Unless you acknowledge that fact, I'm not saying that you just go out and advertise, look, NEC rate is 25% or something, but you need to acknowledge within that this is a problem and we need to tackle this problem. Because why one unit has 25%, another unit 20 kilometers across has 5%? Is there a difference in, I mean, it could be difference in definition. Like when I presented you international data, there are a lot of discussions before they allow me to present, because they say, oh, are we talking the same thing? So standardizing and collecting the data and reviewing the data would be the first driver. The second would be the willingness to not openly discuss. I mean, we still have our data when we present. It is A, B, C, D, E, F. A knows who is A and B knows who is B. So in 2003, 4, 5, nobody was talking. Nobody was saying that, oh, I am C. Now when we meet in the meeting, people just stand up and say, I am Z and I need help. Who is A? I want to come and talk to you. I want to come to your unit. I want to sit down with you for one day and watch what you do. And we facilitate that. We say, okay, well, you should go there because this is what your problem is. So key driver first is the data, second is the openness, and third is the support from the hospital organization or the unit where you want to implement such activity. Because which method you use, which intervention you target, with what works in your unit, I can't tell. I mean, there would be unit with a hand hygiene compliance of 90%. If I tell everybody, okay, now everybody has to work on hand hygiene, that unit is not going to be interested. They need to find, okay, what is their issue and what is their barrier, and then go. So we provide a list of the things that works, that has been shown with some degree of evidence, not always randomized evidence, but some degree of evidence that it can reduce BPD. And then the unit will look at that list and say, we are doing it, we are doing it, we are doing it. We are not doing it, but we are not interested because there is not enough evidence. And then the next one is, we are interested. I think we should target this next. And that's what we left them, that you decide, but you have to do something and come and present so that everybody else knows that you tried this and it didn't work. I mean, there is going to be failure. All these PDSA cycles are not progressive. Some of them will fail and you may not get the same answer, but you always will learn the process about it.
Thank you so much, sir. I think that's a great way forward for most of us who are working on quality improvement in India and in other LMIC settings. Now, I think there's some issue with my display, so I'll request Adisivam to take forward the rest of the questions. Adisivam, can you just take forward the questions?
Okay, sir. Thank you.
Yeah.
The first question is from Jagdeep. Are the needs of QI specific to each country? USA needs are different in QI compared to India. Your comments, sir.
Yeah, absolutely. I think each unit will have to decide as to what is needing in their particular place. What this different methodology will give you the framework to work on. I'm not saying you use PDSA or you use this. Choose any method, but you decide what is your own need in your particular unit as to what you want to achieve, what you want to reach, and what is your goal. Definitely, it will be different in different environment, different area. There is no point in working on something to improve care of 23, 25 acres when things are not going well for 27, 28 acres, which are more in number. So one will have to work on their own local context, and that is the APICS concept. Our context, our main concept is how can we work with the local context and learn from others to apply the evidence or evidence-based quality improvement projects within our own set.
Thank you, sir. It's always better that we think globally and act locally. So the next question is from Dr. Kedar. How do you address adaptive behavioral barriers? Adaptive behavioral barriers.
Yeah, I'm not sure what it is, but basically, how do you make people to adapt to change? That probably is the idea of this behind this question. It is hard. It is the motivation. It is what people need to see concrete example and a concrete idea, concrete results in front of them before they will agree or listen to you or understand you. So you can't just throw every 3 months a new quality improvement. You need to show that this is what we were targeting. And the base example, the hypothermia example I showed you, is just to say, okay, well, 30% of our babies are cold when they are 1 hour of age. And that will startle people that, okay, well, why? How can we do better? And then you show them that if we do this things, it went down from 30 to 15%. And people will start believing. And then they will come to you and say, okay, well, but 15 is too much. How can we go down to 10? So that's how you tackle adaptive behavior, is to show an example.
Yes. The same gentleman has also asked, are you using digital platforms for documentation of projects and data?
Yes. So what we have is, I mean, do not expect that every unit is going to start collecting every detailed data that you need. So what we told the units is that on the gross basis, we will basically, you collect the gross outcome data and some characteristics data. But if you are implementing a project, let's say the surfactant project, right? What you do is you are the one who is going to collect that information and keep it with you. Because I can't tell everybody to collect the surfactant data, because that's not a problem in their unit. Or even if there is a problem, they are not tackling that problem, they are targeting something else. So those are called process indicators. So the process indicators to be collected by local unit, the outcome indicators collected centrally for the comparative purposes. And for both of them, you need electronic platform. For the process indicator, you don't need fancy thing. I mean, you just need to decide that, okay, we are going to collect temperature on the babies and which baby got hit and what time the baby got hit on the baby's head. There are 3 indicators that you need to collect, and you will have outcome data in front of you. But for the global comparison, or when you're going to network, or when you're going to compare yourself to the state level or the NNF level, then you need a harmonized data set, which could be electronic or paper or something, but ultimately need to be converted to electronic data.
Thank you, sir. Now I request Professor Vikram Datta to continue with the moderation.
So Adishivam, I unfortunately am not able to see the question, but I'll just put up a very important question from our side. I think may be of interest to many of the people. Professor Shah, I just wanted to know, and this is more so in the international focus also right now, there's been a severe disruption because of the COVID in the quality of care, especially in the maternal and neonatal healthcare domain, quite significantly. And in India also, we've seen a lot of disruptions, not exactly quantified like you mentioned. So I want to ask your experience about the international network. What is the level of disruption you've observed in the maternal neonatal health services across countries, and your experience in Canada, how to restart the process and the advocacy for QI in wake of the pandemic, which is taking, more than a year to abate?
Yeah, no, thank you for that question. It is very important. And when our pandemic started in the March of 2020, when started to get the first case, but the cases were there in January, February, but not as a panic level that we understood, kind of thing. And that's where it started. And our initial response was basically shut down, like light was shut off. People can't come to the hospital. We did that, like it was like a shut off light kind of thing. And that did lead to reduction in the maternity services part, because the regular appointments were disrupted. People were struggling to figure it out, what will help, how can we do virtually, how much we can do virtually, how much we need to do physically. and a lot of disruption happened. And in that process, there was a lot of uneasiness amongst the healthcare providers to do it virtually, like seeing a mother, pregnant lady at 28 weeks and not putting your hands on or not doing an ultrasound and stuff was disruptive. But they have learned kind of thing. Fortunately or unfortunately, whichever way you want to look at it, our business in neonatal world did not reduce because baby kept on coming at the same rate as they used to come. Not much change in the prematurity as well, not much change in extreme prematurity. So our units, though they were at a standstill in terms of innovation or doing further research, quality improvement activities were slowed down but continued because there wasn't a flurry of babies coming to the NICU because of COVID. Right, the number of babies didn't change much, so that complement, but the staff anxiety, staff level of worry and perception did change, and that did affect people being off sick, not off sick, and process flow mapping and stuff. When we met in February of 2021 with all the units, we just learned from all the units that there was a little pause during March, April, May because of the new normal, but every unit continued to do the quality improvement activity that they were doing, because they realized within 2 to 3 months that we are not bombarded with more babies. Our census is remaining same. So we just need to continue to provide. The one thing that was affected is the parental participation, because there was restriction in the number of parents, and those restrictions varied from one parent, limited time, one parent, full time, two parents, then back to one parent. So those part disrupted. And we keeping an eye to see that, okay, how does that has affected a baby's growth and development? Because they play a major role in our units to come and take care and do the skin to skin care, as we know now, the way you guys have done in a way we're trying to mimic, but not achieved yet. So that was affected, but not much of the quality improvement work by the unit. And by September, they all picked up back to where they were in terms of the quality. Now, outcome changes, we'll have to wait till the data comes in and flows in properly to see whether there was a reduction or increase in infection associated with COVID.
Thank you so much, sir, for that scenario. I think India also has a similar situation. It picked up very soon. For the neonatal colleagues, the disruption in terms of tertiary care units was very little. But from the peripheral units, the primary and secondary, the disruption has been quite significant. And the magnitude, according to WHO estimates, is quite significant in LMIC settings. We still have to look at the data and the outcomes. So that's one. Adi Shivam, please take forward the questions. Thank you so much.
Thank you, sir. The next question is from Prashant. Out of the 5 QA methodologies, is any particular method which is superior over other?
Sorry to disappoint that, but no. All methods lead to good outcomes. So just choose one process that you want to adopt and follow that adopt. There is not one better than other. Some work better with the flow and process issues, and some work with the others. Some work better with implementation issues. So there are two aspects of it. If you have a process or flow issue, I think just to deconstruct it, like the way I showed the yellow and lavender colored cards, just deconstruct the process. Think of, is there any other step that I need to work? Is there any other step I need to improve? And then deconstruct it so that it will help. But there isn't one that will work better. These are all coming from the industry. And that's why I'm telling you not to use those wordings of a lean technology and Sigma, and it's all confusing. Just use simple word. We want to improve quality, and this is what we will do. And I think plan, do, study, act concept gets well understood by the non-doctors people as well.
Prashant has also asked, please explain process mapping and driver and affinity diagram tools. Process mapping, driver and affinity diagram tools.
So let me share the process mapping part. And So this is what we call it the process mapping, in which basically you define your problem on the right side, which is percentage of babies who are not receiving skin to skin care following birth. Let's say it's 30% you identify. Then go backward and say, can I put any of the processes that are causing this into these 4 buckets: people, place, policies, or procedure? People, meaning thereby mothers are unaware of benefit of skin to skin care. Similarly, clinicians are unaware of the benefit of skin to skin care, right? So those are the people issue. Place, is there any control of temperature in the room? Are there operating theaters too cold? Is the delivery room too cold? And that's what is leading. So that's a place. Policies, do you have any policies to train the staff? Do you have any skin to skin care policy? We don't. And that's a policy issue. And procedure, what do you do when the baby is born? Routinely place the baby under the warmer, or you place the baby on the mum? So do you have hats? Do you have warm blanket? These are all procedural issues. So this is how deconstruction would be process mapping. Okay, and those are the variations of the driver tool as well. It's basically one and same thing, working out a different mechanism. I would not be hung up on, oh, I don't know the driver affinity tool, or I don't know this. It's brainstorming the cause. That is the most basic underlying premise of it.
So we have quite a few questions. I'll be quickly taking. We are running out of time. So we have a question from Chandra Bhagat. Chandra wants to know, there may be a rumor of third wave of COVID. How can we prepare for quality of care? So I believe you just answered that question, but any additional points, sir, which you would like to add?
No, I don't think I have any additional point. Even if the third wave comes, I think within the context of neonatal care in the tertiary unit, it will not change. But I think you may have to work on the primary and secondary care where mothers come, because I have seen a couple of reports of increased stillbirths.
So, sir, thank you so much for that. We have a question from Dr. Sri Sailam Koturu. Dr. Sri Salam wants to know, in whom did you find it easy to bring a behavioral change, the medics or the paramedics?
Behavioral change, it's easy to do it in the paramedics than the medics. I mean, we doctors, we want to do the same way. We are hard ones to be changed, because this is how we do it, kind of thing, the concept. But once it opens up with the whole community, and then they also start asking you question, but why? That's where the doctors change. It's not difficult to do adaptive behavioral change in paramedics.
So I believe, sir, most of my Indian colleagues will also agree. You've been doing quality improvement here, including Adisivam, Manoj, everybody. That it's Surinder is also here. Dr. Saurabh Datta is here. A lot of eminent colleagues are here. That it's more easy to work with the paramedics in terms of adoption of the quality improvement. Sir, we have a question from Kedar again. He says, are you using psychology of change framework of IHI in your daily practice of improvement? There's a white paper, beautiful white paper by IHI on psychology of change, more so in times of COVID. So we are finding it very useful in India in times of COVID and also in day-to-day working. So what's your experience about the IHI psychology of change framework, sir?
No, absolutely. So we are using it consciously or subconsciously. And the way we have done it is to engage them and make them the champions. So what we have done is, our champion for any intervention that requires a lot of nursing help is 3 nurses who are the quality champions, and they are the trainer model. So they will talk. So if I go and tell the nurses, they will listen, and then they will go back to what they used to do, kind of thing. But if the nurses tell the nurses and show the data, it makes more impact, kind of thing. Somebody might do it because I am telling them to do, because I am the doctor, but that's not going to make quality improvement. That will be a forced work. So yes, we do use the psychology of change framework. We go back to the unit and discuss with them as to what works for their own unit. And we do focus group of the non-doctors and the doctors separately to see that, okay, well, what do you think works in your unit? And it's revealing to learn. Some units the hierarchy works, and in some units the framework of how everybody works together works. So each unit is different, and we feedback that this is what works in your unit, so you may want to bank on that.
So I think, sir, you just answered the question from Dr. Ravi Kumar. Dr. Ravi Kumar wanted to ask, how do you motivate your team members? I think you just covered that part. So just out of curiosity, I wanted to know what sort of quality improvement trainings do you provide to your staff? Is it on induction? Is it on duty change or shift change times into, postings intra-wards? Or it's on routine, annual appraisal linked trainings and capacity buildings? What sort of national policy do you have for the quality improvement trainings? And what about the pre-service quality improvement trainings in the Canadian medical schools?
Yeah. So all, I mean, you're touching the high, very, very important points, different points. So the quality improvement training within the unit, we have adopted the model of train the trainers. So the 10-step model that I showed you, we have a 4 to 6 hour workshops that we run online, and then train the people. Once you have attended 2 or 3 of those kind of thing, then you can go to the trainer module, and we train them, so then they can go back to the unit and train the other nurses. So we can't train everybody in every unit, but we have adopted that model that they go back and stuff. At an individual unit level, people have used the different. People have used newsletters. People have used the charts. After initial resistance, it is now accepted. We just put our infection data right as soon as somebody enters the unit. So even parents can see it, doctors can see it, nurses can see it. We have a board which will say last day since catheter related infection. And whenever it becomes 0, it's like, oh, what happened? So everybody is happy as soon as you go 30 days, 31 days, 32 days, 0. And then it's just like, what the hell we do? How can we do it better? So it just changed the culture. Parents, don't be afraid. Parents, we were afraid that, oh, parents will look at it and they say, oh, this is the hospital where infection. They didn't. They were saying, oh, great, you're doing great. So we know now what is happening in your unit. So it's kind of a visual management. We also have a board where we ask nurses to suggest changes. No, not nurses, everybody working there to suggest that, okay, well, as soon as I open this door, it bangs with the noise and all the babies get startled, and then the heart rate goes up and the alarm goes up, and then I have to go. So it's a simple fix. You call the engineering and fix the door. But it reduces the noise, reduces the environment, improves the mental status, not people running around. So all those things helps. So locally, that's what the units do. We also have a lot of visual material to pass it on for the parents, pass it on for the healthcare providers. Nationally, we provide this training workshop, and then we yet haven't linked it to the appraisal part that you asked, because that's a difficult one to do. Our the whole system has gone to the CEO performance pay measure. So our CEOs are getting performance pay based on performance. So then it will trickle down. They will want you to do, they will hospital to do better. But I wouldn't recommend that model yet or anywhere kind of thing. And finally, the medical school, we do this training workshop now started to do in the medical school. So all the medical schools are being trained, and the residents, we have a project that we give it to every fellow to be engaged in a quality improvement in addition to whatever research they're doing. So trying to attack it multi-pronged. I'm not saying that we are most successful or we are doing everything, but it works in many places. Different thing works different places.
Thank you, sir. Adisabam, can you quickly take forward the next questions, please?
Abhishek Paul has asked about Pareto chart in simple terms. Can you explain Pareto chart in simple terms?
Yes, just a minute. I'll share it. Yeah. So what Pareto chart is here on the left corner at the bottom. So when you are doing the process mapping or you are trying to find the brainstorm the causes, what you find is that there are five things that are affecting And these are the 5 things in order. But once, what happens with the Pareto is that when you address the 3 most important or most common reason for anything, any process to go wrong, you will get 80% improvement. After that, if you have a 6, 7, 8, 10 other causes that you want to tackle, the gain would be only 20%. The remaining gain would be only 20%. So first address the first 3 points that will give you the maximum bang for your bucks. And that's the Pareto chart is. So how to prioritize so that the first 3 are addressed, and that will give you improvement by 80%. And that is the Pareto chart. So that's the exercise you do when you do your brainstorming of the causes. And when what I showed you in terms of rating, like how do we choose? So if you place a hat, use a warm blanket, and raise the room temperature, will reduce your hypothermia rate by 80%. There are a lot of other things that will be there, but they will be less rewarding. That's Pareto chart.
There are 2 more questions almost similar. One is asking about how to involve the community. The other one is about involving the government machinery into our QA initiatives. Community and government machinery into QA initiatives. What are your takers?
I think present your findings and present your data, and show that this is the change. This is the problem. This is the issue. Show them the comparator, that this is what we should be striving to. And in order to do that, go with the process map. Do not go with the problem. Go with problem and solution, or impending solution, or planned solution. That is what will attract the people. People are tired of hearing, oh, well, our infection rate is too high. Oh, our infection rate is too high. They know that. They don't need to be badgered constantly in knowing their infection rate. Is that the next step is that this is our infection rate. This is the national standard or local standard or state standard we should be striving for. And in order to reach there, we need to sit down and talk. And this is the process. Once you have a whole process lined out, then go to the administrator and say, we need support. Because this is going to ultimately save cost. Right? Ultimately, it will save the money. And that's what attracts them. So to different people, you speak different language. And that's what probably will happen.
Well said, sir. In our country also right now, for the birth attendant, the government is trying to introduce a Lakshya program. In our own hospital, we have introduced a bonding angel program, wherein we have used the nursing students to reduce the time of first feeding or the feeding initiation for the baby. And that's also going well with no added expenditure for the system. Once we reap the benefits of small quality initiatives, then as you said, everyone gets interested and tries to give a helping hand with the ongoing activity. Thank you very much, sir. I think we have completed almost all the questions which have been posted here. May I now request Dr. Manoj to take over.
Well, thank you once again, Prof. Prakesh Shah. It was truly an amazing talk. Nice of you to share your priceless experience in this need of our concept, be it in resource-rich settings or even in resource-limited. So you have made the concept so simple. Thank you so much.
Thank you.
We look forward to having you again with us in the future sessions as well, as I was talking to you previously. Now, let me also thank the moderators of today, Professor Vikram Datta and Professor Adisivam, for moderating this session so very well. And finally, let me thank all of you friends from all around the globe who joined us today. We are truly honored to have you. Please do continue to join us to listen to the legends in our upcoming sessions as well. We have on 22 July, Thursday at 7:30 p.m. Antenatal steroids and update by the legend we all look up to, Professor Alan Job from University of Cincinnati, USA. Until then, good day, good evening, good night.
Good night. Thank you.
Thank you so much. Thank you so much.
Thank you.
Thank you.
Bye.
Bye bye. Thank you.